afternoon. So, when first Uni gave me this, you have to talk and he gave me something like this, deep thought. I was thinking, like, what is this deep thought? So then I understood the concept behind it. So at the outset, I don't have any financial disclosure to make. So this image is quite common to us for the retina surgeons. It's an ICG image where we are trying to look at the choroidal vasculature. So we've been looking at retina and retinal vasculature and retinal structures quite often, like without much problem, because they're easily accessible to see them and then assess them and analyze them. Whereas choroid is something which is not that easy to see because it's being blocked by the structures in front of it and the vasculature. It's a highly vascular structure. If you look at it, the choroid is one of the highly vascular structure in the body. And that's what is supplying to the more sensitive layers of the retina. The outer segments are getting blood supply from the choroid. So that's why the people started getting interest in looking at choroid. Like everybody gave a deep thought at that time, thinking that, okay, how do I look at choroid? What's happening there? Because that might give us a clue in many diseases which we are looking at. If we look at most of the retinal diseases, they involve the outer retina. And what we are doing right now is trying to look at retinal vasculature, which supplies the inner retina, but we are not looking at the outer retina, the blood supply which is coming from the choroid. So that's where people thought deeply, is there anything which we can do to look at choroid? Came up with an ICG, look at choroidal vasculature to some extent. It gives a blood flow. And try to look at the choroidal thickness by doing a B scan. It has been there for quite some time, but it's not that sensitive when you look at choroidal thickness with B scan because the resolution is not that great. So why is it so difficult to look at choroid? As I said, like the RP is something which is blocking it, so that's why the regular angiograms will not let you examine the retina choroidal vasculature. And if you look at the OCTs, the penetration, the same problem comes with penetration. The RP is going to block, so you're not going to look at the choroidal details well with the regular OCT. And to circumvent this, there are other technologies and techniques which we used with whatever we had with spectral domain OCT. So I'm going to touch only on the spectral domain OCT. I'm not going to get into swept source OCT or adaptive optics OCTs, which can image choroid a little better than what we can do with the spectral domain OCT at this point of time, though they are not into regular commercial use that often at this point of time. So what we have in clinics is only a spectral domain OCT. And how do we get a little more information about choroid using a spectral domain OCT, and what is that which you are looking at, and what is the literature which we have till now is what I'm going to emphasize on. So that's what is called enhanced depth imaging. So what does it mean? Enhanced depth is like, if you look at an OCT, so this is the depth. Till now we were able to look at these layers well. The choroid is deeper to it. So by increasing the depth of penetration, we are able to look at the choroidal details well. So till now we were looking at what are the coastline and ISO extension or external limiting membrane till that now. So now we wanted to look at what happens beyond that, so the deeper layers beyond that. That's what we're trying to see. So how do we do it? So when you look at the regular OCT, the images of choroid are not that great. You can get a good layer of RP, ISO extension, external limiting membranes, but the choroid is still not that clear. But the image which I've shown you, you see that it's little more clearly seen than what the regular OCT shows. So what we do is, when you look at an OCT, anyone who has done an OCT, when you are focusing an OCT, you get two images. Once you focus, an inverted image comes if you go push further beyond. So that means the sensitivity of an OCT at the different layers based on where you focus. So if you push it further, you're going more deeper. So your sensitivity increases at the deeper layers, it decreases for the superficial layers. But if you want to look at the choroid, so you try to push it so that you will get the sensitivity more at the choroid, you will get a more clearer choroidal picture. But the problem there is it's an inversion of image. So you can do that by a regular OCT, just pushing it closer that way. So that's what is called zero delay line. So you look at this image. So this is what is a regular OCT when we take, and you see the choroidal details. You can see some amount of choroidal vessels here, but the retinal structure is very well seen clearly. The same thing if you push it further, image inverts, and you start getting more details about the choroid. So that's what we're trying to do by pushing more towards the zero delay line. So you can actually look at the outer border of the choroid and sclera junction, whereas see, this is a regular image where you can see that clearly. You do this and invert it manually. There are machines where you can do it automatically. You just click on a button and it does that automatically. So if you have that, then you don't have to worry about it. So you can actually see the junction. So you can really measure the thickness of that there. When compared to a B scan, it's more sensitive when compared to that way. But at the same time, you don't get this clear images always. So there is always a possibility for you to get images like this. So only when you have this image like this, then only you can be sure that you are measuring the outer border of the choroid. But when you have image like this, you are not sure. So that's something which you need to understand. There is another way of doing it. So if you look at this images, this is the same patient, but with the same machine. The first scan is unaveraged. This is a single line scan, one scan taken. This is a scan where it's 4 scans taken at one point. So you club everything together, do a software analysis, you might get this. This is a scan which is taken with the 20 times at the same point. So increase the number of scans and do an averaging of the scans, you might get a better depth perception. That's another way of doing it. There are many OCT machines which gives you this option right now. Some of them will give you a multiple scans taken at the same time. Some of them will give you only one line scan which can be taken at a higher number of scans. If you look at a spectralized machine, it might give you, you might take 7-8 scans, it can go even up to 100 times averaging. Whereas a Zeiss machine might give you only 20 times, but only you can do one line scan. But that is another way of looking at it. There is a third way of looking at it. That is by changing the wavelength of the light source which we are using. So if you increase the wavelength, the penetration is more. So use a 1 micron wavelength, you might get this scans without doing all the other techniques. So that's the third way of doing it with the regular spectral domain OCT. But most of the machines will not have this possibility of changing the light source. So for all clinical purposes in our regular clinic, the first 2 methods are the ones which we can use, whereas this one is a complete different light source which you might not get in a regular OCT machine. So what are we looking at in choroid right now? So if you look at histological layers, there are 3 layers in the choroid again. You see a thin dark band there, that's a choriocapillary band which is seen there. And the next layer is the layer of saddler where inner choroid with a smaller caliber vessels, which are the dark round structures are the vessels there. Whereas if you go to the outer part, you see a larger vessels, those are the layer of Fowler. So those are the things which you can actually look at when you look at an enhanced depth imaging. So it's not just the thickness, you can actually look at the characteristics of these layers when you have a good image. And it will definitely help you to identify what's happening there. So you look at the choroidal thickness in normal patients, yes, people have looked at it, there are different variations, and the choroid is not uniformly thick, and there is more thicker in subfoveal area, and there is a variation in different areas. And it's just not the areas, it's even the choroidal thickness changes even during the day. or with the blood pressure fluctuations. So the reason why I'm telling you this is, many times say that the choroidal thickness is this. So it's just like saying that at that point of time the choroidal thickness is that, but it doesn't mean that that's what exactly it is. You might change the point of where you're measuring, the choroidal thickness varies, and the time of the day when you're measuring, it varies. So you have to keep all these things in mind when you are actually looking at the choroidal thickness. So that's the reason I'm telling you that it's just not the choroidal thickness you have to look at the choroidal characteristics also. So that might give you extra information to know what exactly is happening there. So let's look at a few of the examples in regular choroidal thickness in different retinal diseases which we commonly come across. The common diseases where you know that it affects the choroid is central serous retinopathy, AMD, uveitis, and choroidal tumors is another thing which is an interesting area where we can actually look at an OCT and see what type of tumor it might be. So one piece of information which you need to understand is in myopes. Look at this. This is a normal emetrope. Thickness is ranging from 230, 220 to 230, 300, whereas this is what happens in myopes. It's a thinned out choroid which looks like. If you look at the ratio between the choroid and retina, this is quite different. So that's something which you can always get information from. And there is another concept that most of the retinal diseases which are developing in case of myopics might be related to this, because the choroid is already thinned out, the blood supply to the retina is compromised. That's a concept, but I'm not saying that that's what actually happens, but that's a concept which is being thought of. So coming to the central serous retinopathy, which is one of the common diseases which any retina specialist or even a general practitioner might encounter. The choroidal thickness. The choroid is supposed to be one of the main reasons for central serous retinopathy. So increased choroidal permeability is the one which thought to be the culprit for cause of leakage into the subretinal space, causing pigmental detachment. And if the people have tried looking at the choroidal thickness in those cases, and it has been shown clearly that the choroidal thickness is increased. So it means to say that maybe we are looking at a disease where there is an increased permeability or there is some vascular changes happening in the choroid, which is resulting in what we are seeing as a subretinal fluid in these patients. So there are studies where people have looked at what happens if I do a laser in these patients and try to look at choroidal thickness in these patients again. When you do a focal laser in those patients, it's not shown much change in the choroidal thickness, whereas if you do a PDT in those patients, there is definitely shown there is a change in the choroidal thickness. And when you look at the hyperpermeable area on an ICG, it correlates well with the increased thickness of choroid in that area. So it gives us one information that by doing a just focal laser, you're just sealing that leak, but you're not doing anything much beyond that. And by doing a PDT, you're doing something more than just doing a focal laser. It could be good, it could be bad, because you are showing an effect on a choroidal vasculature. It could be bad, but the PDT might be causing a permanent damage to the choroid. That's another thing which is coming out of this information. So you might have to consider that's one of the reasons why we started doing a low fluence PDT for these patients, so that effect of that is little less. So that's it. That way the OCTs help you in central serous retinopathy. Coming to the AMD, does that make any sense in looking at choroid in AMD? Yes, there are some studies which tells you that maybe the decreased choroidal perfusion is one thing which is causing the AMD. But if you look at this is one definite case where it might help you looking at the choroidal thickness. This is a case of a central serous retinopathy. Look at the choroidal thickness here. And this is a case where there is an AMD, where the choroidal thickness has gone down. And this it can help you to differentiate whether we are dealing in cases where you are in confusion. Okay, there is a doubt whether I am dealing with a CSR, or maybe if RP modeling is seen there, you're not sure about it, you might be able to identify by looking at the choroid whether I'm dealing with central serous retinopathy or an AMD. So usually the choroid is thinned out in AMD because most of the times choroid thins out for a period of time. It changes with age. So if you look at older people, the choroid is thinner. So that's another thing which you can actually look at in this. So most of the AMD patients, the choroid is thinned out. So another hypothesis where what's happening there is choroid thins out and the blood supply there was compromised, and then that's the reason why the AMD is happening. Looking at diabetic retinopathy, so does that make any difference? Yes, but not in PDR patients, but in the PDR patients, yes, it does make a difference. And there are some Doppler studies which have done in diabetic patients, which definitely shows that there is a change of blood flow to the retina in case of diabetic retinopathy. So diabetic retinopathy does have vascular effects in the retina and choroid. So we still have to work more and analyze more to see what exactly the changes are. But one disease which definitely the OCT is helpful is VKH, where if you don't have much inflammation, looking at OCT choroidal thickness will definitely help you to diagnose or help you in diagnosing VKH, and it's definitely more sensitive when compared to V-scan in looking at choroidal thickness. And you can actually look at the choroidal thickness over a period of time when you start the treatment for these patients, and look at the choroidal thickness coming down. And at the same time, to look at the choroidal infiltrates, you look at the vasculature of the choroid in active disease. You don't see vasculature that clearly. So that's basically because the inflammation is happening there in that area. So there is an inflammatory cells, there is an edema there, so there is a thickened choroid. So it's not just a thickened choroid. You can actually look at the architecture of the choroidal vasculature, which might tell you that, okay, the disease is still active. So we need more studies to assess at what exactly the characteristics which we need to look at to decide activity, but then definitely there are some changes which we need to assess. Coming to the tumors, can we look at tumors? Yes, there are smaller tumors that are difficult to pick up with B-scan. So do an OCT, you might be able to get the characteristics of the same tumors. This is a nevus, which is a small lesion. You can actually look at the outer border effect. You can measure the thickness, keep following them up. It's good for following small tumors. If you have a big tumors, it might be difficult. So, but look at this architecture. There is a change here. You don't see a vasculature there. So this is how a nevus looks like. So they don't see much vessels inside. Whereas melanomas, if you look at it, there is a large melanoma you can see here, and you don't see the outer limit. So you can use OCT for measuring this, and for following up of these patients to see whether this tumor is growing or not, or what is happening. But you can definitely look at the vascular pattern which is inside this tumor, which might give you an idea what's happening there. And that's one of the things which might help you to differentiate whether it is a nevus or maybe you're looking at melanoma. This is the case of a hemangioma. You can see the number of those black spots are more in this than when compared to what was seen there in the melanoma. It's basically because the choroidal hemangioma is a compilation of all multiple vascular channels there. So that's, you can actually get a good idea by looking at an OCT. Then cases where you are having a doubt about amelanotic melanomas, something like that, look at OCT. It might give you a clue. I'm not saying that you can diagnose this definitely, but that's another clue, another information which you're going to add to your already having information with B-scan or FFA and ICG and all these things. Add everything together, you might come to a conclusion. I'm not saying that OCT is going to give you a definite diagnosis in this. So looking at the patterns might help you to come to some reasonable conclusion. So looking at an osteoma, you can actually see there is loss of vasculature here. You can even see the clefts which are seen in the osteomas which are seen histologically. So those are the things which you can actually look at by doing an enhanced depth imaging. The limitations are we don't have still an automated segmentation like what we have for retinal thickness maps. People are still working on it. The main problem there is you need to have large areas to be mapped first, and then to be scanned first and to get a map. enhanced depth imaging might not be a good idea at this point of time. With the regular spectral domain OCT, you might not get that information. Maybe with the different technologies, you might still be able to do it, but that's still a long way to go right now. And medium opacity is definitely going to make it more difficult for you to look at choroidal lesions. So in conclusion, basically, we have OCTs with us, so we can definitely look at choroid, and it definitely gives us more information than what we used to get with the regular OCT machines. And it helps us in few diseases at this point of time, and might help in more diseases later on when we have more studies done.